Dr. Szekely. Well, now I go over to the introduction of Dr. Szekely. Andrea is Professor of Anesthesia and Intensive Care in Sunrise in Budapest, Department of Anesthesia and Intensive Care. She has been elected as President of the Hungarian Society of Cardiovascular Anesthesiologists. She is a member of the Training Exchange Program Committee. She's examiner of the European Diploma of Anesthesia and Intensive Care and the EACTA IC Abstract Reviewing and Pediatric Congenital Surgery Committees. She's actively involved in the Frailty Task Force of the European Association of Cardiovascular Surgery, and she's an editorial member, board member of the GCVA and the Journal of Pediatric Medicine. So, Andrea, we are delighted to listen to your presentation. Thank you very much.
Okay. I would like to say also thank you, and I would like also to say a very nice evening. Just the weather report in Hungary, it's rather rainy, but just before the sunset, it's just become a little bit shiny and it stopped raining. So anyway, I would like to show my slide about my conflict of interest, which is actually about my broad approach. So it's not closely to the topic that I would like to present now about the anesthesia of the transplanted patients. And there are a couple of very good publications and papers or even chapters which deal with this topic. In the outline of this presentation, I would like also to talk, but from another approach, about this denervation heart problem. Then a very short overview of the immunosuppressive drugs, some good notes to the preoperative evaluation, then about the anesthetic drugs and interactions, and short take-home message to the best practices. So as we have heard previously, then the denervated heart has a total other physiology, and it usually remains, even there are a couple of papers about the new innervation of this transplanted heart. But very importantly, there is no response to parasympathetic stimulation. There is also no response to neuronal sympathetic nervous system stimulation. But if we administer epinephrine, there is still affects the heart. The resting heart rate increased 90 to 110 per minute. There is no response to hypovolemia, vasodilation, or even for exercise. And also the response to the renin, angiotensin, and aldosterone system is delayed or attenuated. And then it has a normal resting inotropic state. So you can see here in this small diagram, then the straight line is a normal heart, and compared to it, the resting heart rate is higher. But actually, the denervated heart will never exceed, even after peak exercise, the same performance than it does the normal heart. It's also a very interesting paper just about this topic. Then this paper compared the occurrence of atrial fibrillation after cardiac transplantation, and they compared it to patient after CABG surgery and also after MACE procedure. And they have found that this double loss, so I mean the loss of parasympathetic activation or innervation, and also at the same time the loss of sympathetic nervous system activation can reduce the occurrence of the atrial fibrillation about 4 or 5 times. compared to the after other procedures. Here is a list, and let's say it's a very good table which shows the most important side effects of our immunosuppressive drugs. As you see that that tacrolimus, for example, cause renal dysfunction, hypertension, hyperglycemia, or also hypomagnesemia and neurological problems. I would like to emphasize the problems related to the mycophenolate. It usually causes gastrointestinal problems with diarrhea or other such complications. And we exactly know the side effects of the chronic steroid treatment, which our transplanted patient have to receive at least for a half year. And what it means, we had a transplanted patient who had previously variable severe end organ dysfunction, which then after the transplanted heart, it's remained partly, or it was, let's say, it's the reversible part was disappeared, and then the organ dysfunction, mainly the renal and the liver dysfunction, improved significantly. But on the other side, he then started the immune suppressive drugs, and that's why after 10 years of transplantation, the occur or prevalence of hypertension is 97%. Severe renal insufficiency 14%, hyperlipidemia 93%, diabetes 39%, and the presence of angiographic confirmed coronary allograft vasculopathy is also 52%. We also know that tacrolimus has interactions with different drugs, just because these drugs are inhibitory or even synergistic effect have on the cytochrome P450. We can measure increased tacrolimus levels in case of administration of calcium channel blockers, or if we use ketoconazole or fluconazole and a couple of other antibiotics. But the tacrolimus level can decrease in the parallel administration of carbamazepine, rifampicin, and phenobarbital, and we have to count with increased nephrotoxicity in case of the co-administration of amphotericin, vancomycin, ranitidine, and of course the non-steroidal anti-inflammatory drugs. So what kind of perioperative problems can appear before and even during operation, and how we have to deal and how we have to proceed with the preoperative evaluation. So first of all, we have to check the patient and we have to look after signs of rejections. We also have to determine the graft function. We have to exclude the presence of infection in case, of course, in planned operations and elective surgical procedures. And we have to know exactly the medical history of this patient. And of course, even if in any questions, we have to communicate with the transplanted center and with the eventually with even with an expert transplant